So we proceed to beautiful Vera Ehrenstein. So, okay, Vera. Vera is also a clinician, right? You
No,
all,
no,
no, but you're a
no,
physician.
no.
No?
You
What
mis
are you?
you misclassified
I'm
me.
misclassifying you because you're so, you know, because I try to steer clear from codes as much as possible. Really, if I don't want to know, I just get the algorithm, please. And Vera instead is passionate about that, and she can distinguish. So that's why I thought you cared about that. I am scared by codes.
Oh, you are?
Yeah. Yes, terribly. And
Thank you.
so you can introduce
Thank you.
yourself and tell me why is it that you are interested in code and why is it
Yes.
that you like validation though?
Thank you so much for invitation. This is fantastic place. Why I'm interested in misclassification, why I'm interested in validation, the reason is most of what I learned in my career is I learned from my mistakes. And misclassification is everywhere, really. And misclassification can be huge. I mean, we're here in Italy, right? Christopher Columbus misclassified present-day Bahamas as Spain, and then he misclassified Cuba as mainland China. And then, of course, some of us flew today to the Amerigo Vespucci International Airport, and Christopher Columbus sailed the ocean blue in 1492, and we named America after Amerigo Vespucci. So misclassification is everywhere. Misclassification and epidemiology. So Vin has already talked a lot about this. So thank you, Vin, for saying everything that I was going to say. Wrong classification of study subjects by the algorithms, by the phenotypes, classifying treated as untreated, cases as non-cases, confounder present as confounder absent, and vice versa. And of course, we often have very complex scenarios when we don't have binary variables. So this is what we call measurement error, aka information bias. And of course, we all know the epidemiologic mantra of that non-differential misclassification of exposure, biases towards the null, and we also know that it is not always true. And I tell my students, do not write your discussion section on autopilot, because that is not the case often in epidemiology, and especially when we talk about safety, right? We might be okay with diluting an effect when we talk about effectiveness, but we are not so okay with it when we're talking about safety. Okay, so this is very simple example of the sources of error that might happen when we use a list of codes as an operational definition of our study variable. This is from a validation study of an algorithm to define epilepsy. Very simple, ICD-10 code G40. There was 69 cases that were subjected to validation by medical chart review, and so you see that out of those 69 cases, only 52 were confirmed by medical record to be true epilepsy. And then you can see all kinds of things that would have counted as epilepsy had we not done this validation study. So, okay, seizures, suspected seizures, okay, I can see that coding error, but unspecified heart failure, why is that there? So this is just an example of very simple misclassification. And I think the PPV here would be what, 75.4%, and maybe it will be a little bit higher if you would include seizures or suspected seizures, if you would be so generous to include them as potential epilepsy. Just an example. So Rosa asked me to talk about the ISPE guideline, you call it, Rosa, but it really isn't an official guideline by the International Society of Pharmacoepidemiology. It's a paper that was supported by them, that was reviewed by ISPE membership, some of the people who sit here today. And the motivation for that ISPE guideline was, or ISPE manuscript, as I said, were mistakes and difficulties that we had in actual studies. And we're talking about early days. I think this post-authorization safety study of crizotinib in lung cancer patients, it started, if I'm not mistaken, in 2017. It was early days of multinational studies. The study was conducted using databases in Denmark, Sweden, Netherlands, Finland, and the United States. We used Optum database. And so we're supposed to validate, we had many outcomes. One of them was, for example, some disturbances of EKG, so QTC, QT prolongations, and then the sponsor of the study, which was Pfizer, they came to us with a validation manual where they had a very nice case definition that you see here on the screen. So this is a clinical definition of the QTC prolongation, and then if you see any of those in the medical charts, which we used as the gold standard, you would classify a case based on, in our case, on some codes in the databases. You would classify that as a definite case. Well, you can see here, I don't have a pointer, but you can see, for example, the bottom, the second point from the second bullet point from the bottom, change of 60 or more millisecond from baseline. I mean, if you go to a medical chart at a hospital, where's your baseline? You don't have the baseline. So the thing is, when you have this beautiful randomized control trial based definition of a case, you often, your gold standard or reference standard does not have all the information to confirm a case or to refute a presence of a case. So that was a difficulty, and we tried to adjust our case definition to the type of gold standard that we have, but we were not always successful. Another outcome that we examined in that study was vision disorders. Again, the language came from clinical trial of crizotinib. Okay, and then, so you classify a case as definite if obstruction form include evidence any of the following conditions, okay? So far, so good. That's a long list. But then this was the next instruction. And this is what the chart abstractor needed to sit with and ensure that, okay, if a patient had any of those listed there, then that is not a definite case. So how do you go about that? And so in addition to the paper that we published based on the results of that post-authorization safety study, we kind of published the lesson learned paper where we try to be a sounding board and tell everybody about our pain, about our mistakes made in this study, and the most important lesson that the trial-based definitions are often unsuitable to use in studies based on routinely collected data. So this was a kind of a motivation for us to come out of our comfortable offices, and though this was for me really a wake-up call, because I knew how to do validation studies from my EPI courses, but I couldn't find a source that really nicely laid it out for me, how to do it, what to do, and so on. So then we approached the International Society for Pharmacoepidemiology and with this proposal to write up a guideline. And I think maybe, Vin, you were working on the same thing at the same time. We just didn't know about it. So this was a group per ISPE rules. It was supposed to be a group from different sectors, different countries. So you can see here my wonderful co-authors, most of them from Denmark, most of them from academic institutions, and coming also from the United Kingdom, Japan, United States, covering the regulatory sector, mostly from academia. I don't think we have industry represented here. Okay, so here's the structure of our paper. So first we talk about algorithms, then we talk a little bit about completeness of a data source, measures of algorithm validity that Vin was just talking about, gold standard and reference standard, which measures can be estimated in a specific validation study, how to prioritize validity measures, portability of algorithm, size of a validation study. So all the nice things Vin just covered. So this is a guideline I wish I had before I started the crizotinib study. And we come from the premise that we're in a learning healthcare system. So we have the patient's bedside, and there is some treatment going on here that has clinical aspects, diagnostic process, treatment decisions, disease outcome. And then in this day and age, it goes into a patient record and then trickles down to a database where we do our multinational studies, publish beautiful papers, which come out as evidence in guidelines that are then used to treat future patients. So future patients, learning from past patients, nothing new about that, but we're more formal about it these days. We kind of expect that these days, also on a large scale. So already touched upon by Vin, the diagnosis paradigm. So we diagnose, or doctors diagnose a disease in clinical practice using specific tools. We diagnose disease in the population using our operational definitions. So also examples of the algorithm, we start by defining that in our paper. So you have, for example, ATC code group JO1, antibacterials for systemic use. You can use it in many different ways in your studies. You can use it as an operational definition of bacterial infection, or you can use it as an operational definition of exposure to a systemic antibacterial agent. There will be some misclassification of that record. And this is an example of a paper. And so also an example of how you can maybe add some more elements to your algorithm. This is an algorithm also of infection. Now we're interested in a serious infection, and we define that by going to a hospital and identifying patients who have had a diagnosis of infection in a hospital. That's condition number one. And condition number two, they have to have that diagnosis listed in the main field, in the main diagnostic field. This is an excerpt of the Danish National Patient Registry. So an example of two different algorithms to define different types of infections depending on the study needs. Okay, so also in the paper we have a glossary of the terms that we use. So we meant this ISPE paper as a reference material. And then in the supplementary material, we give a lot of studies, example studies of validating operational definitions in real world data. And then we also have in another supplement, we have such a sort of textbook material where we present all the validation metrics, including sensitivity, specificity, predictive values, ROC curves, kappa statistics, and so on. And then validation designs. So depending on how you sample your validation study population, that determines what type of validation metric you can actually estimate. And this is a wonderful paper by Fox, Lash, and Bodnar, which already came up. So you have three options, probably more, but three basic options. You select on algorithm, on operational definition, or you select on truth, on the clinical condition, a confirmed one, or you don't select on any of those. And so depending on how you assemble your validation study population, that's what the part of the 2 by 2 table that you can estimate in the validation study. So I think we've all seen this table. So if you select algorithm positive and sometimes also negative persons, you can estimate PPV and also NPV for any or each component of your algorithm. And the reason, this is what we most frequently estimate in our validation studies, and that's because it's just too costly in terms of resources and money to do otherwise most of the time. If you, in the second scenario, select on the gold standard, so you would identify an independent sample of a gold standard positive events and non-events, if you can afford it. You can estimate sensitivity and specificity of any or each component of the algorithm. And then that's the part of the 2 by 2 table that you can estimate in your validation study. And then the third scenario, which is always preferred if you can, but often it's not possible, you just select independent of whether of the value of either the algorithm or the truth. You take a population of patients and you have treated, you have patients with and without the condition according to the truth, and with and without the condition according to your algorithm. And then you can fill out the entire 2 by 2 table, and you can estimate sensitivity, specificity, positive and negative predictive values. Gold standard, it is ideally a perfect, but in reality, a better measure of the event, the health event of interest that is measured by the operational definition. It needs to be suitable to provide that case, non-case definition. And very frequently we use medical charts. I think Amir will talk about how exactly we do that as the gold standard, but we can also use other sources, such as patient histories in electronic form, or we can also use another database. My colleagues in Denmark, by the way, hi guys, I think you were watching uh, in the conference room. My colleagues in Denmark have validated diagnosis in the Danish National Patient Registry, diagnosis of cancer, and they validated a lot of them against the same diagnosis in the Danish National Cancer Registry, and that is the gold standard. I think we can really talk about gold standard in many cases when we talk about cancer registry. Just to stop for a few minutes on medical chart review, we spent some time in the ISPE paper on talking about what to think about when planning medical chart review. And because of that crizotinib study, where we're really burnt by some of the things. So you want to define the ascertainment time window. So if you have your algorithm with a date, but maybe, as Rosa said, maybe there is a delayed recording, you want to make sure that you capture that event in your gold standard. You want to make sure that you allow enough time where to look for for the truth. You have to make sure that the types of records that you have access to contain the key records that require to identify your case and non-case definition. If you need lab values, make sure you have access to lab values. And in our case, laboratory tables were separate from other medical chart reviews. So we had to do some jumping through some hoops to get the laboratory results needed. Make sure that you have access to records by key specialists or departments that provide information about case and non-case definition. What is the mechanism for obtaining additional information, resolving disagreements? We know we probably want to use more than one adjudicator and maybe a third one. But if there are some questions coming up, how do you go about obtaining additional information? What about the actual chart abstraction? Who does the chart abstraction? Is it of course, trained personnel who needs to check certain boxes, and then the case, non-case status will be determined by an algorithm? Or do you want to allow that a clinician with specific knowledge reviews medical charts, and do you want to allow, perhaps in addition to checking those boxes, that clinician to make their own diagnosis of a condition based on what they read in a chart? So, and then, as I said, you have to consider whether and to what extent to adopt the event definitions from randomized trials. Just to wrap up, in our paper, we made a case for the learning healthcare system. We're now conducting safety studies and also effectiveness studies and comparative effectiveness studies, a lot based on routinely collected data in medical databases. So in addition to having skills and validating our algorithms, maybe let's start one step earlier and try to make a case for whoever makes the record takes care to make it right, so that our sensitivities and PPVs increase over time. So I hope we made that case. And yeah, maybe one more thing is that we all know that if you have a very large study, a very precise study, creates sort of an illusion that its study is very valid, which is not the case, right? And as Darren Daly said in his Twitter post, put it plainly, highly accurate estimates of the wrong thing are especially wrong. And I just made it as an example the study, not because it's wrong, because it has 52 databases in it. It's just be careful. Because something is precise doesn't mean it's valid. One argument for validation studies, as I tell to my students, they're very highly cited. Maybe they're a little bit boring to do, but they're highly cited. And so, as Ken Rothman said in his paper, My Interviews John Snow, research accomplishes more good and brings greater health to humanity than more intensive doctoring would ever accomplish. And so I think we just have to remember that it's a huge responsibility of what we do, and we need to ensure our data are good. So thank you so much. Let's wake up again. Yeah. Oh, I forgot about considerations for researcher. I'm just going to leave them there.
Thank you very much, Vera.